Okay, I'm recording. Hey, welcome everyone to the Rowan Alumni Association monthly webinar series. This is a new series. I'm Dean Machichi. I'm the Assistant Dean for Student Affairs and Alumni Engagement at the medical school. We're very glad you could join us for this evening for our very first webinar. It's a panel presentation. It's a new program featuring SOM alumni. Each month, we're going to bring this to you to share important information on relevant health topics. Format of the webinar series will include a panel presentation and a Q&A, and we hope to do this all within 1 hour. So tonight's panelists will be speaking about surviving COVID-19, a physician's perspective, which will be followed by time for questions and comments from attendees. For those attending, please submit your questions in the Q&A so that they can be shared with the panelists during and at the end of the presentations. We are recording tonight's webinar, which will be available on the Rowan-SOM Alumni Association website for future viewing. We are looking forward to an enlightening discussion about a condition that truly has affected everything and all of us. I would like to thank all of you for joining us this evening and thank our alumni panelists, of all of whom are also members of our SOM Alumni Board and tremendous supporters of the school. Let me introduce them right now. Dr. David Ballard, class of '86, family medicine physician and partner with Premier Health Associates, LLC, located in Sussex County. Dr. Ballard is also the president of the New Jersey Association of Osteopathic Physicians and Surgeons. We also have with us Dr. Ashkan Ashanawi, class of '99, a pulmonologist and sleep medicine specialist with her own practice, Pulmonary and Sleep Disorders of New Jersey, located in Middlesex County. And then we also have Dr. Troy Randall, class of '03, cardiologist with Lourdes Cardiology South Jersey Heart Group, located in Camden County. Troy is also the program director of the Cardiology Fellowship at Rowan-SOM. Also on the line with us is Gail Foreman, our senior director for advancement, who really put this all together. So huge thanks to Gail, and Brittany Mitchell, coordinator of student affairs, alumni engagement, who will be assisting with today's program. So I now hand the program over to our esteemed moderator, Dr. Ashkan Ashanawi.
Okay. Can you hear me?
Yes.
Okay, great. Thank you, Dean, so much for that introduction, and thank you for inviting me to be part of this. I'm honored to do this with all of you. So just to give you a brief introduction before I pass it on to my colleagues, I'm Ashkan Ashanawi. Like Dean said, I graduated from this wonderful medical school in 1999. I went on to an internal medicine residency in New York City at Beth Israel, and then did my pulmonary fellowship at Memorial Sloan Kettering Cancer Center and my sleep fellowship at NYU Medical Center. Since then, I've been practicing pulmonary and sleep medicine in Middlesex County. I currently work at Penn Medicine Princeton Health doing pulmonary work, and I am medical director of the Center of Sleep and Breathing Disorders at St. Peter's University Hospital. And probably my proudest thing is that I am a member of this board of the alumni at SOM. So Dave, Dr. Ballard, would you like to introduce yourself, please? You're muted.
Can you hear me?
Yes.
I'm unmuted now? Hi.
Yes,
Dave
you're
Ballard,
unmuted.
I'm a family physician, 1986, class from Rowan. I really am happy to be here. It's very funny, you know, this COVID thing was probably the low point of my life, and I tried to forget about it. And then Gail asked me and Dean asked me to remember it. So here I am, and I would tell you a quote came to my mind, and it's, "Nothing is as thrilling as being shot without any effect." And that was Winston Churchill. I kind of feel that way, you know. It's like, wow, I can't believe I got through that. Now there's a little bit of that adrenaline rush from actually recovering, you know, and seeing people who don't. So I can talk to you a little bit about it, but it was a scene, man. That's what I would say. Thank you. I can't.
Hi, I'm Troy Randall, class of 2003. I am a cardiologist with Lord's Cardiology, Virtual Cardiology, formerly South Jersey Heart Group. Very involved with the school. I did my residency as well as fellowship here in the program and decided to stay local. And as Dean mentioned, I am the program director of the Cardiology Fellowship. Looking forward to discussion about my experiences as well, seeing both sides from the physician standpoint as well as the patient standpoint. And I think it was, just eye-opening in terms of the survival of this and how do we move forward.
Great. Thank you, Troy. So glad to have you on the panel. So I'm going to just start with a very few words about COVID. I don't want to insult anyone out there. I know most of you know everything there is to know, mainly from CNN, but I just want to make sure that we're all on the same page before we let Dave and Troy tell their stories, and then we can talk about it in more detail, okay? So let me just make sure my screen is shared here. All right, everybody see that? Okay. So just a little bit about why we're talking about COVID as if it was not obvious. This is probably the only pandemic that we have all witnessed in our lifetime. And unfortunately, it is far from over. And as you can see, and these numbers are just from yesterday, and sadly, they're already up from these numbers when I looked today. But we have close to 3 million cases of COVID in this country, and we have over 130,000 deaths thus far from COVID-related complications. And as you can see, unfortunately, we were doing well, but now it looks like we are on the upswing, and we will talk a little bit about that as well. Just briefly, transmission of COVID, again, so we're all on the same page. Primarily, we do know that COVID virus is aerosolized via small droplets from the nose and mouth, and that could just be from talking, sneezing, coughing, being close to someone, singing, all can transmit these droplets and infect the other person. Secondarily, and we're getting more literature on this and evidence that there's actually virus particles that are airborne. And what that means is someone could be standing in a room, be infected with COVID, and just breathe normal air or can cough, and hours later, someone else can walk into that room and it's still airborne. So you don't necessarily have to have direct contact with that person. So that's a little scarier. And so even more reason for protecting yourself. And again, we'll talk about that very soon. Recently, CDC ran a survey, and it said that 50% of patients can't even identify who may have infected them. So that's another scary thing. And we'll talk to Dave and Troy about who they think may have infected them. No names, though, but just an idea of who may have gotten right. No threats. So it just means that there's a lot of community transmission that we may not know about, especially from asymptomatic individuals. The median age of hospitalized patients with COVID-19 so far in the first 3 months have been between 49 to 56, actually, because I know there's a lot of myths going out there that only if you're 70 or 80, you're going to get this. It's so not true. And the incubation period for this virus after exposure to actually having the infection and being able to transmit it is within 14 days, but usually 4 to 5 days after the exposure. And the last slide before I introduce Dave and Troy again, symptoms of COVID-19, going from most common to least common, and hopefully can help you physicians out there when patients come and talk to you about their symptoms. The most common symptom is being a dry cough. Next in line is a fever, muscle aches, headaches, shortness of breath, sore throat, diarrhea, nausea, vomiting, loss of smell and taste, and then finally abdominal pain. All right, I am going to now turn over, I think we'll start with Dr. Dave Ballard about his story, and let us know how he thinks he got infected with COVID, his timeline, what he was treated with, and how he's doing now. Dave?
You can hear me now? Yeah. So, you know, I don't want to go too in depth, but I would say somewhere, I'm pretty sure March 4th, I was at a county dinner, medical dinner, and everybody was elbowing each other, and one fella came up and gave me a kiss on the cheek. And I immediately excused myself and washed my face, which was kind of rude at the time, but I said, no, I don't care. And a couple of days later, that guy had COVID. And then 7 days later, I had COVID. So there was a pretty good timeline that was it, but you can't tell because I had been to New York City the week before that twice and to a concert. So you really don't know. And I'd been seeing people with flu-like illnesses in the office. They were masked, I was masked, but we weren't as cautious as we are now, even though we masked those people because influenza wasn't that, you know, infectious as this seems to be. So that's kind of where I think I got it, but you never know, and it doesn't matter. It's just past tense. So it started with just flu-like illness. Everybody has it, you know, you get achy, you get fevery, and the fever, the thing I noticed is every day the fever got higher, 99.7, 100.7, 101.7, 102, 103. And I'm going, whoa, this is really impressive. But there was nothing more about it that was worrisome for the first week, except the relentlessness of it. And the relentlessness is a thing I would say, you know, every day I noticed that I wasn't better. And in fact, I felt a little worse. And that peaked on about day 12 when trying to walk approximately 6 feet from my bedroom to my bathroom, I couldn't do it. And I had, was holding on to a counter and I called my friend, the critical care doctor. I said, dude, I'm in trouble. And he says, call 911. And they brought me to the hospital. And when I got there, my pulse ox was 78. And I remember that going like, that's kind of bad. I didn't feel as bad as my pulse ox was. And I guess that was what they'd call silent hypoxia. I don't know, because I really didn't feel as sick as I apparently was. And at that point, you know, I had all of those markers, the ferritin and the CRP and my blood sugar and all those inflammatory things were way up. And they said, Dave, you're in this cytokine storm. We might have to put you on a ventilator or whatever. And I said, well, whatever we got to do, just make sure I'm asleep if you do it, because I don't want to deal with that. And I felt that there's a sensation you feel that people don't, unless you feel it, you can't explain it. But I think it was this dying kind of feeling internally. You have this strange feeling, you have a calmness, but you just know you're not well. That's probably the best way to say it. And I'll end with the story of, there was 6 doses of Actemra in the Atlantic Health System. And infectious disease friend of mine said, I got you a dose, I'm gonna get it to you tonight, because tomorrow they're only giving it to people who are in the ICU on the ventilator. So starting tomorrow, we're gonna give it to you tonight, and there's 6 doses. And he actually drove the dose up to the hospital. I got it at 2:30 in the morning. I passed out. I woke up, it was 9 hours later, and I felt different. That's all I can say. I didn't feel like I was dying. So whatever that storm was, they cut it off, and this Actemra really worked for me, Actemra. And from that day on, I felt I wasn't going to die. It just had a prolonged recovery, and the recovery was weeks and weeks and weeks. And that's kind of the story. It was a kind of an amazing thing to, you go to sleep saying, I think this might be it, you know, and then you open your eyes and you feel different. And that's the best thing I can say. And then it took me another month to recover, but I kind of knew I was gonna from that time. And that's kind of my story. It was amazing. It's amazing to live through. That's why I said, I quoted Winston Churchill.
How long after your initial symptom till the time you were diagnosed?
So I had very minimal symptoms initially. I had like a little lack of ambition, which is odd for me, for about 2 or 3 days, which I just didn't feel like doing anything, but I didn't feel sick. And I started taking my temperature just out of, you know, curiosity, and it was normal during that. And then I had a little ankle pain, like if I ran too far the day before, you know how your ankle would be sore in the morning. As we get older, we feel that way. And that was like a day, and I was like, that's odd, because I hadn't been running. And then the following day I had a 99.7 temp, and I knew I had it that day. I said, I got COVID, that's it. And I went to my infectious disease friend and he did the nasal swab. It wasn't back for 5 days, but I was so sick by the 5th day, we kind of knew we had it already, so that's how it worked. It was very difficult to get the test results back.
All right, and I asked that question as it relates to the entire community, not just your household, obviously, but it's very important to try to figure out where you got it, not so that you can say you gave this to me, but more because, well, who else were they around, and who did you possibly expose from that moment on, within 5 days till the day you got the diagnosis. Because as we know, we're getting the diagnosis days and days after the swab. So what happens in those few days?
So I can answer that. Yeah, it's an interesting thing for me. Luckily, am I on? Luckily for me, I was supposed to be in Europe, so I was off that week. So I had no exposure to anybody but Mrs. Bollard really for 5 days prior to getting sick, and so. When I got it, it was so early in the disease process in Sussex County. I think it was like the 2nd case. The health department did a background and they talked to everybody and they said, you really haven't exposed anyone because you weren't anywhere except for home. And I had been out of work for 5 days already, 6 days before I even had any symptoms. So they said that probably work was okay as well. So it kind of looked out in that respect. I didn't get too many people sick, hopefully.
No, thank God. And how did it affect your practice in general, like then and now?
So 3 of our physicians ended up, out of the 30 some got COVID, and then 2 of them were hospitalized. 3rd one should have been hospitalized, but he fought it out in his bunker in the basement. Luckily got through it. And obviously changed the way we practice. They closed down for a couple days, and then we went to into battle mode, and we stopped taking any salaries, and we just tried to keep our employees employed. And we went to the virtual medicine, which is kind of not that good, but you have to do what you have to do, and it's better than nothing, which is what we were doing. So, and then one doctor panicked, which I never understand, and he said, I'm done. I'm going to move to Arizona, and he actually resigned, and he's moving to Arizona, which I understand is not a great place to be right now for COVID. So the answer there is nowhere is safe.
There's nowhere safe. Can't escape it.
That's the thing, yeah.
Okay. My last question to you, Dave. Do you have any significant residual symptoms today?
So the biggest thing I had for about 4 or 5 weeks after I was getting better was 2 things. Extreme fatigue, like the kind of fatigue I would explain, and you'll get it, is hour 28 of a 36-hour shift. That feeling before you get that next adrenaline boost, like continuously feeling that way. And that lasted for weeks. And then I called it COVID brain because I don't know what it was, but it was kind of like a mental sluggishness, which I had, which was very frightening when you do this for a living. I was like, oh man, this is not going to work. It slowly cleared, and I can feel it coming on. When it comes on, I just have to take a break, like walk outside for 10 minutes, and then my head clears, and then I come back. So stress kind of triggers it, and taste is gone. Hopefully it'll come back, which for me isn't, probably a blessing because I'm too heavy, but.
I have read that the taste does come back a few weeks or so after the initial symptoms resolve. So there's hope.
Yeah, it's been a while now, but it's kind of down.
It's been months now.
Yeah.
Yes.
Yeah.
Well, hang in there. We're delighted you're here with us and you're able to tell the story.
Yep.
Thank you.
It was a scene. Thank you.
All right, we're going to move over to Troy, Dr. Randall. Please let us know, similar questions to Dave, how this all came about, and how are you doing now?
So I believe that I picked up COVID from a colleague. So not a patient. I'm very diligent generally with my protection, PPE, even pre-COVID, hand washing and all. During that period of time, I had a routine when I would come home, get undressed in the garage, run, take a shower before I even interacted with anyone in my family. But And cardiology, we have reading rooms where we sit in a small room and we read all of our echoes and nuclear studies. And I believe that that's where one of my colleagues who had became ill, known COVID a few days prior to me becoming sick, we shared that room for probably a week. So that's where I suspect that it happened to me at. And I felt fine, actually, at the beginning. I was working, didn't feel anything. The day that I became ill, driving home, I kind of felt off. I don't know how to, describe it. Like, I didn't feel like I was sick, but just somewhat off. But after my routine, like I said, when I got home, I got out of the shower and I felt like I just got hit by a truck just all of a sudden. I struggled to get to the bed. Then I had fevers and myalgias. And I think that was the worst part for the first 5 days. Fevers as high as 103, the body aches, headaches initially as well, first couple of days. And I generally don't get headaches, but I had headaches. And for that first week, like Dr. Bala said, that first week was just a very bad flu. I luckily didn't really have any respiratory symptoms. I had a non-productive cough. I monitored my pulse ox. 1 minute, during the day I would be fine, and then all of a sudden I would crash. I didn't luckily spread it to anybody in the family, because the minute I was sick, I just isolated to my bedroom. And because I knew that my colleague had COVID, that was the first thing I suspected. So I, protected my family. It took about a week for my test to come back. So by the time my results came back, I felt relatively well. The biggest thing, though, at that point in time was just shortness of breath with prolonged exertion, which I usually don't get, and fatigue. By 2, 3 o'clock, I felt like ready to crash. And, I'm someone that can push to late hours of the night. But by the end of the day, mid-afternoon, I was hitting a wall. At that point in time, I think healthcare professionals were cleared to go back to work if you were symptom-free for 72 hours. So after, I think, about 10 days, they cleared me to go back to work. And then 3 days into that week, I started getting headaches again. And then I'm like, did I not recover fully? Because again, I don't get headaches. I thought I didn't recover fully. We were a little short in our practice because we had a few physicians that were ill, so had a tough time covering the hospital. I felt bad to ask one of my colleagues to cover 2 hospitals, especially after I had been out weeks. So I went into work with a headache for 2 days. And then, I really knew I didn't feel right. So I started reaching out to colleagues, infectious disease, pulmonary, and we were setting up to get retested again. They said that sometimes they saw some relapse after a 2 to 3 week period. So I was setting up to get retested. I personally knew something was wrong with me. I left my house because as a very stoic male figure, no one in my household has ever seen me in a weak state of mind. So I left the house and went for a walk, and I had prayed and just started crying because I couldn't identify exactly what was wrong with me, but I knew something was wrong. Later that night, my wife had a meltdown because she knew I was not myself. So she was pressing me to go to the emergency department. I was resistant initially because I said, if this is just a relapse of COVID, they would tell me the same thing that I did the first time, just quarantine at home. But she became very emotional, started crying. And then I had agreed to go to the ER only if I knew who was working. So I think she called 3 hospitals before I found out one that I would go to. And part of it is I didn't just want to go to an ER because I wanted a CT of my head. I just knew something was wrong. And I think as an average individual, if I would have presented, I probably would not have obtained a CT. I don't know if it was right to partly direct some of my care, but I think knowing the individual help persuade to get the CT in my head, and thankfully we did that. That part was frustrating as well, because there was an abnormality that was noted on my CT, and they weren't sure if this was vascular, being a stroke, or if it was infectious. And they did not want to do a lumbar puncture, not knowing what was going on. So we talked about treating with antibiotics while they get an MRI to see exactly what was going on. We knew the MRI would be somewhat delayed, so I agreed to antibiotic therapy, and then the MRI showed that I had a 5 centimeter cerebellar infarct. And I spent 2 days in the neuro ICU, treated with aspirin Plavix at that time. And I think during that period of time, I was somewhat afraid. I called, not called, I sent a text message to my family telling everyone how much I love them. I tried to leave some inspiring words for my children as they're in college, because no one can come to the hospital. So I had no idea if I was going to make it out or not. But then when I was diagnosed with the stroke, I think it was somewhat of a relief for me, because at that point in time, physically, I knew where I stood. I felt okay, and I felt like I had an answer, and I could move forward from that.
Wow. Thank you, Troy. I really appreciate your candor and sharing this with us. I know how ridiculously emotional this was for you and your wife and your family. I think Dave and I were smiling when you said, I had to first make sure I knew who was in the ER, had to make it, we're just control freaks, and God forbid, and nobody takes care of us, right? Yeah. So we are the worst patients ever. So I'm so glad your wife sent you to the emergency department.
Yes.
Because I probably would have done the same thing as you. Headaches, it's just my COVID. I know what they're going to say to me. I know what I need to do. But I think the message that we have to tell people who are listening today, especially, is it is called a novel virus for a reason. We don't know the extent of it, even though we know a lot more than we did in March. We really don't know the extent of it. And I found there were times where, when I was practicing in the hospital seeing COVID patients, especially in May and June, I felt like I was a medical student again. And I felt like I was learning medicine for the first time, because COVID, this virus, was not reading the same books that I read in medical school and in my residency and my training. So it was a very humbling experience. And I think for both of you, I think it was a tremendously humbling experience, because you had to take off your doctor hat for a moment, or more than a moment, and be a patient and trust the healthcare system. Do you think the healthcare system served you well, or did it fail you miserably? Troy?
Loaded question.
Loaded question. Let's be honest here. Come on.
So I think initially we struggled in the healthcare system, and this is before I had COVID, because we were not quite prepared to handle what was coming at us. And in terms of like the PPEs and the masks, like we didn't mandate that the staff was wearing masks initially. We were concerned about conserving supply. So I think that left us vulnerable at the very beginning. We improved with that as time had moved on. During my illness, though, I would say that the healthcare system did their job. I felt totally, cared for, and received quality care during the illness. But I think initially up front, we struggled. One of the things with my stroke was, as you said, with coronavirus, this is novel. we had no idea about strokes at the time that it happened to me. Like, we knew about the respiratory issues. We knew about, some PEs with the clotting, but the literature and data about strokes actually didn't come out until a week after my stroke.
Absolutely. Dave, would you like to add to that? How about your experience being a
Sure.
patient, and
Yeah.
were you surprised by anything?
Well, it's actually, we talked about, should I go to the regional medical center or the community medical hospital that I grew up in and worked in for 30 years? And I opted to go to the community hospital where I grew up and worked for 30 years. Absolutely saved my life doing that. I was not just a patient, I was Dave, and I think I had great treatment, and the people, I knew the people, two of the hospitals worked for me, which I'm a good boss, so I think they liked it. They took good care of me. I knew the ER physicians. I knew a lot of the nurses. I knew the VPMA, the infectious disease doctor. Like I said, went down and got me the dose of that medicine. He said, I've known you for 30 years. If anybody's going to get a dose of this, it's going to be you. So he told me. Critical care doctor's my partner. So I knew I was getting top-notch care, and I knew within 12 hours I was going to be okay. I don't know if that would have happened if I went to a big hospital. I can't say, but I don't think it would have. So yes, they did a great job. You're muted.
I think what I'm thinking, and what probably on people's minds is, well, I'm not a doctor, and if I were to go, would I have known to say, scan this, or I need this drug, or I'm doctor? I mean, I always think about that for the person who, I'm not saying not educated, but doesn't have that medical know-how, that they may not give the relevant history, they may not ask the right questions. And I've always thought about that in years past with, different scenarios, but I think it's something worthwhile to consider as our non-physician,
That's why osteopathic family doctors treat everybody like their family members.
Absolutely.
So,
Absolutely.
I'm going to tell you the same thing I'm going to tell my sister or my brother or my aunt or my cousin. You're going to get the same advice. That's how it works, That's why people love what we do.
Absolutely. God
Yeah.
bless. Troy, quick question. Did you have any balance problems or gait problems? It seems like the neurological symptom was mainly headache. And with the cerebellar stroke, we typically see gait and balance issues. Did you ever have that?
So, luckily I did not. And that's part of the reason why I was not thinking stroke initially, just from the headaches. Neurology thought that they saw some fine motor deficits on exam, but no true balance or strength issues. I do get some dizziness and vertigo if I move too rapidly. So I try to compensate for that and avoid very rapid movements.
Great. Okay. And my last question for you, Troy, is currently, as you're practicing, are you able to go back to the hospital, treat COVID patients? Are you doing them differently? Has this affected your practice currently?
So for me, I'm currently not in a hospital. Initially, it did not affect me. Even after the stroke, I was ready to go back full force day one. And despite neurology telling me to take things slowly, I felt like I, could get back out in the trenches. And I had a major setback when I went into the hospital setting. I think part of it was wearing the N95 mask, probably right after the stroke. So the dizziness and vertigo symptoms that I had complained about was improving for like a 2 to 3 week period. But after getting in the hospital wearing a mask, I had a major setback and probably crippled me for another like 24 to 48 hours. I looked for some literature about wearing masks post strokes and really didn't see anything. But thinking is it some hypoxia, hypercapnia that's happening with the masks. So with that being said, neurology has pulled me totally out of the hospital, at least until things settle down with COVID, and I'm just seeing patients in the outpatient setting where I don't need the N95 mask.
Got it. I think that was very wise, and not to rush things because we're involving the brain. And as you were talking, I was thinking the most analogous thing I can think of in medicine to what you're describing is when someone has a significant concussion. And we've all had patients with concussive injuries, brain injuries, and they're recovered, quote unquote. Weeks have gone by, they're recovered, they feel better, but then they go out and go full force, and they get all the same symptoms back. Because guess what? The brain was not just not ready to go back full force. And I feel like that sounds very similar to what you're describing. So I think you should listen to your brain and give it some time. It will get better, but I think you just need to give it some time.
Yes, thanks. I appreciate it. The other part is also fear. I mean, as I mentioned before, my family never seen like a weak side of me, right? So I present as though I'm always strong, but this has placed a fear inside of me that I've never felt before.
Right. And I think it's very honest. And I know I personally was petrified the first week I went around on COVID patients. That gets better, I promise. Not that you get completely hardened to it, but it gets better. You start focusing because you have a little bit more knowledge and you know what you need to do to stay safe now. You know now more than you did that first week when you were in that reading room. So I think you take that and that gives you confidence. So, well, I'm so glad both of you are on the mend. So we will continue our presentation. I'm just going to take up a couple of more minutes and then we're going to shift over to questions because I have a feeling we have a few, right, Brittany? Yes. Okay. All right. So I'm going to share my screen for 1 second to kind of wrap up what we've been talking about here. Okay. We talked about this. And just quickly to talk about risk factors, just so everyone in the audience knows, and the primary risk factors that have been defined for people with COVID and have serious complications from COVID include cardiovascular disease, such as congestive heart failure, coronary artery disease, diabetes, both 2 and type 1, but 2 more so, chronic obstructive pulmonary disease and emphysema, cancers, chronic kidney disease, obesity, and we've noticed in the incidence studies that have come out that male gender, Hispanic, Blacks have higher complications and unfortunately a higher mortality rate when they are infected with COVID-19. Secondary risk factors you can see there, asthma, hypertension, and of course smoking is always a risk factor. Okay. And just quickly to review, some of this has already been discussed by our panelists. Some of the clinical manifestations we're seeing in patients in the hospital, the most common by pulmonary is pneumonia, and it presents with fever, shortness of breath, cough, and infiltrates on both in both lungs. We have acute respiratory distress syndrome that usually gets you admitted to the ICU and gets you mechanically ventilated. We now know that, which we didn't know in March, that we try really hard to avoid mechanical ventilation because people just don't do well after mechanical ventilation. Pulmonary emboli we have seen as a very common complication. So we are evaluating and treating people very aggressively now. Again, we did not do that day 1, but we got to know it very quickly. Cardiovascular, we've seen arrhythmias, we've seen heart attacks, we've seen shock. Neurologically, as Troy presented, we're seeing strokes, even though it's uncommon, we're seeing embolic, ischemic, and hemorrhagic strokes after COVID complications and illnesses. Seizures, encephalopathy, and I think both of you described something like that, whereas the confusion, the hard time concentrating, that's all forms of encephalopathy and likely from lower oxygen levels. And of course, the cytokine release syndrome, and I think, Dave, you lived it, you felt it. It's just cytokines coming at you right and left for more than a few days usually. And really quickly, and then we'll take questions, the treatment includes oxygen if you require it. We always have to rule out and treat a secondary bacterial infection with COVID, although we found that it's very, very uncommon that patients have also a bacterial pneumonia. We again prevent and treat for venous thromboembolism or clotting in the lungs. Treating fever and pain, there was a whole controversy about ibuprofen when we first started. Now the evidence is really not clear that ibuprofen really was harmful to people with COVID, so it is actually okay to take it if needed. Inhaled medications, very important detail. We do not give nebulizer and CPAP treatments in the hospital, even if patients unfortunately require it. It's because that risks aerosolization of the virus in the air, and that can infect many, many staff members that are taking care of that patient. So we can only reserve that treatment for home. And of course, if you're on cardiac medications, please continue them, especially statins, because we know that cardiac disease is a complication and a risk factor for COVID complications. Remdesivir is one of the newer drugs that a lot of people have heard about in the news. We were using it on emergent basis and basis of availability. Unfortunately, not very available, but I'm hoping it's going to become more available. And it's been shown to reduce the clinical improvement time. So from the time you're diagnosed and have symptoms and the time you're able to be discharged without oxygen and care, it's been shown to do that in some of the studies. Dexamethasone very recently out of the UK for people with severe COVID, the use of steroids for 5 or 10 days has been shown actually to reduce mortality. So that's a big, I think, game changer, because that's the only one that really has been shown to do that. But of course, we'll know more as the COVID incidence continues to increase. And convalescent plasma, as we know, people who recover from COVID are donating their plasma if they have high antibody titers, and that can help also improve the clinical scenario for someone who's sick in the hospital with it. I'm going to stop right there because I want to start inviting questions, and if there's time, I can always continue. All right, Brittany, if you can help us get some questions from the audience, thank you.
Yes, so the first question, I believe it's directed for Dr. Ballard and Dr. Randall. Did you recently test for, how often do you test for it, and if negative, how long will it present?
So, I mean, I had an antibody test one time just to see if it was positive, which I knew it was going to be positive, or the test wasn't right and it was positive. I don't know what to do with it. I don't think anybody knows what to do with it. Maybe Ashkan does, but I should be immune for a while, at least, I would think. Who knows how long?
Troy, did you want to answer before I?
So I did not have antibody testing. Again, I suspected that it will be positive. I've talked to some people in infectious disease, and the recommendation was to wait until we get a better handle on titers, just because of my known exposure already.
Mm-hmm. Okay, and just clinically, it's frustrating because the antibody test would be, on paper, be very helpful to us, but yes, we can assume you have antibodies, but unfortunately, it doesn't guarantee you'll have antibodies, because I've had patients who've had COVID infection and do not have that, what we call IgG antibody, which just means you were exposed to it and it was a remote infection, whereas the IgM means that you were just recently exposed to the virus, but may not have long-term immunity. Having said all of that, recent data, just we're talking in the past few days, we're seeing that people's antibody titers are actually fading as the weeks and months go by. And just to give you one example of a celebrity everybody knows, Tom Hanks, he went on the news last night and was talking about his titers and his wife's titers, and they were saying, I guess as the celebrities, they can get it checked routinely, and 1 month, 2 months, 3 months, their titers were going way down over a 3-month trajectory. And his doctors were informing him what the data was suggesting is that he may not be immune long-term, and that yes, he can possibly get this infection again. That's morbid news, I know, but stay tuned. So herd immunity, we can't count on that anymore, I don't think. And I hope everyone knows what herd immunity is, but if not, it's basically as a result of people having antibodies to this infection after masses and masses of the population get the infection naturally, like Dave and Troy did, not from a vaccine. We're hoping to get immunity from a vaccine, hopefully soon. Okay. Question.
Thank you. The next question is, if you are seeing patients, how are you now keeping your household members healthy and safe?
Dave, do you want to take this?
So I'm office-based in my practice, and we have very strict guidelines on who can get in the office. So the only people who will really get in would be asymptomatic 3 days before they get sick patients. Otherwise, we screen them out based on their exposure, based on their smell, their rashes, their stomach, their any cough. So we're not seeing sick call, so we've limited our exposure quite a bit. According to the guidelines, if we have our 95 with a surgical mask and a face shield, we should be protected with that population. And that's what we're going under the assumption of. Every room is cleaned down after every patient comes in the room, and we wash ourselves down, after and before each patient. So I think that we're limiting our exposure as much as we can and still be clinicians, and that's what we're trying to do. Now it's difficult when come flu season. I don't know what we're going to do in terms of how we're going to let these people not be treated in the office. That's going to be an issue. But we don't have a negative pressure room in our office, so we really can't bring them in because I can't risk exposing my staff as well as myself. It's not a good thing to get. So we'll fall over that when it comes. But I think we're using, unless you're an asymptomatic person who's going to be sick within the next 2 or 3 days, I think we've done everything we can to protect everybody in my office at this point. That's my answer.
I agree. And I think from an office standpoint, we're doing things very similarly. I would just add that, post office, I'm still doing the same things that I was doing, before I had COVID, like, make sure, washing hands and, undressing, showering before I interact with family. So that helps to minimize any exposure to the family after the end of my day.
Okay. Thank you, guys. Brittany, next question.
Thank you. You're going to have to bear with me. The next few questions are very clinical. So one is, do you think the hypoxia being seen in the pulse ox may be related to the vascular effects causing ischemic strokes, and that's why patients don't look as hypoxic as we would expect?
Okay, so and I wish I could see it on the paper, but if the pulse ox does not correlate with why the patient is not symptomatic with it, is that the question?
It says, do you think the hypoxia, it's okay, the hypoxia being seen on the pulse ox may be related to the vascular effects causing ischemic stroke?
Oh,
Patients don't look.
Okay, I think I understand the question, but I'll answer and you guys can tell me if I answered it. So the pulse ox and the perception, first of all, of shortness of breath or any symptoms don't necessarily have to correlate, meaning you can have a very, very low oxygen like Dave had, and he didn't feel like he had an oxygen saturation of 70 something. I believe Troy's oxygen saturation was pretty bad. I'm sorry, was good, was normal at all times, and he had a stroke. So you see how you can't predict what's going on in the body just by looking at the pulse ox. If it is low, you know something bad is happening, but if it's normal, you don't necessarily know. And there's a lot of reasons for this. So with COVID, yes, you can have an inflammatory response, and that could be responsible for the stroke. You can have clots that go to the brain with a heart defect that can lead to a stroke that way. And you can have a bleed in the brain. If you have no oxygen or blood going to the brain, it can turn into a bleed. And it depends on when you present to the hospital, at what point, your doctor will catch it. So yes, the pulse ox is not necessarily the end all, but it's a wonderful marker for us to see if there's something wrong, at least in the lung vasculature. I hope I answered the question. Okay.
I hope I said it right.
No, you did. I just couldn't hear a couple of words. Sorry.
It's okay. So this is another clinical question. So have you seen a significant number of thrombotic events? If so, are you seeing primarily pulmonary or CNS thrombosis or other?
Okay, I'll take this. I guess I've been seeing in the hospital setting more pulmonary emboli for sure by far. I can count on one hand how many cerebral vascular, meaning brain attacks I've seen. So very few, and I've actually seen mild strokes and TIAs, which are transient ischemic attacks, more confusion and encephalopathy than full-blown strokes, and they're usually milder, thankfully. But I've seen plenty of blood clots in the early stages, and I remember having conversations with my colleagues saying, I'm thinking we should provide blood thinners for just about every COVID patient we have in the hospital. And I remember it went back and forth for weeks, like, well, we don't have the guidelines. And I made the point, it's like, we don't have the guidelines for anything on COVID. We should just do what we need to do, what we think we should do. And then soon enough, we realized, oh my God, people are clotting right and left. And so now there is a guideline that yes, with any severe COVID patient, we are doing prevention blood thinner treatment to prevent catastrophic blood clots in the lungs. And interestingly, I noticed that patients who come in with COVID, if they're already on warfarin or a blood thinner for another reason, like they have atrial fibrillation or history of stroke or whatever, they tend to do better because they are already ahead of the game and already on that blood thinner. Okay, that's it for that question. Anything else?
Yes, we have quite a few more. So this person says, the experiences you are so bravely recounting sound literally. Do you feel there is enough recognition in the community of the trauma of COVID and post-traumatic symptoms?
Troy, why don't you answer that one?
So as a cardiologist, I like to focus on cardiology. I like to deal with like the heart rhythms. One of the things that we saw with COVID was a lot of arrhythmias. And as I've gone through my own experience, one of the things that I think that we have to be prepared to deal with is mental illness. So, whether it's, due to like the financial and economic issues that were caused by this, but also from, recovery of the disease process itself. Again, as I mentioned, myself being fearful of things, mental awareness, mental illness, I think is something that we're going to see a lot more of. And, we definitely, I think, need to be braced to deal with this as we move forward.
Thank you, Troy. Brittany, because I know there's a lot of questions, so I want to get as many people's questions answered.
Sure. The unscientific information going around on social media has worked against the best public health collective response. How do we reach the high school audience with accurate information?
That is such a good question. If you guys want to take it, you can raise your hand. Everyone's shaking. I'm great.
No, I think that's tough for me as well, because there's so much on social media. I actually remove myself from social media because, you would think of it as being a platform for, positive messages, positive energy, but there's been so much negative energy, from the virus itself to a lot of other cultural things. I'm not sure if social media is a great platform for that. It would be nice if the news media would take this lead and try to help with some of the outreach that's positive. I think that would be helpful.
I agree. I think it's becoming even more challenging considering all our teens and college students are at home virtually learning and all they have is social media. But as parents, hopefully we remain their educators. Okay, Brittany.
Thank you. So what do you suggest for college kids going back to dorms and classes?
Okay. I wonder if my teenage son sent this question. Okay. I would, because we've been talking about this lately. I think it's a very difficult question. I so badly want my kids to go back to school because I think we're out on so much, as we all know. However, I want them to have their next birthday, and I don't want them to bring back a virus that can infect us, but more importantly, infect their grandparents who are not very healthy individuals. So that would be tragic. And if it just means another semester or so of online education, so be it. And again, as physicians, as educators, hopefully we're there to help them along at home, along with their wonderful professors. That's my personal opinion, but I know it's going to be up for debate for the entire summer, most likely.
Dorms are disgusting on a good day.
I agree. He's seen my son's dorm clearly. Okay. All right, next question, Brittany. And again, I'm sorry to interrupt, but I know, Dr. Ballard, I know you had something to do very soon, so feel free to shout out and say when you have to excuse yourself. We're going to keep taking questions. That's okay.
So, yeah, I have to go in like 2 minutes.
Okay, wonderful. Thank you again. Okay, Brittany.
Okay, so the big question, how far off is a vaccine?
Well, from everything that I've been reading and from the different pharmaceutical companies, especially in Europe and outside of the United States, as well as the United States, I think we're looking early 2021. So hopefully as early as January. So it might be deep in the flu season, which kind of scares me. So I recommend highly that everyone get their flu vaccines because they are available, and they will be available by probably August or September. So please do go ahead and get that. I know they are not made for coronavirus, but there has been a couple of anecdotal studies that have shown that people who've had the pneumonia vaccines and the flu vaccines and get COVID don't do as badly as people who did not get those vaccines. So at least we have that, so please take it. But of course, as soon as the COVID vaccine becomes available in 2021, we will all be eligible to get it done.
Thank you. So this attendee is asking if anyone heard about Richard Bartlett, MD from Texas, regarding nebulized Bienstein for non-critical pulmonary COVID. Oh, bye, Dr. Ballard. Thank you so much.
I thought you were going to answer the question. I thought you were.
I wouldn't touch that question.
I mean, either. I actually am not familiar with what. Can you spell the name of the medicine?
I think it's budesonide.
Budesonide.
Oh, budesonide. Yes, thank you, Dr. Randall.
Okay, that's different. Okay, very good. I was like, wow, there's something out there I want to read about. Budesonide is a steroid, inhaled steroid medicine that is often used for asthma, COPD, emphysema, and because in theory that dexamethasone, which is a systemic steroid, meaning we take it by pills or IV, that has been showing to improve mortality. The thought is perhaps we can give people inhaled steroid to at least reduce some of the inflammation that is going on in the lungs from COVID. And there's absolutely little to no harm in trying that, as opposed to other experimental stuff that has been proposed in recent months. I personally have been giving that to my patients, whether or not they have asthma. Maybe a couple of more. How many more questions do you have, Brittany? Oh, perfect. And I said a couple more. All right, cool.
So what do you say to the people that think that this is a conspiracy of the government?
Who wants that? Oh, Troy, unmute so quickly.
You like to give me the loaded questions, huh? Of which government or any government?
Let's start with ours.
I mean, this is so novel. I really don't know what to think anymore, right? So coronavirus is not new. Coronavirus has been out there. This is just a different strain of the coronavirus. And when I reflect upon how coronavirus behaves, I've never seen anything behave like this virus behaves. So with that being said, I think you can insinuate whether this is something that is truly a genetic mutation, or do we think that it was something that was, kind of genetically engineered? I'm not sure if we'll ever find that answer out, but again, this does not behave similar to any of the coronaviruses that we've seen.
Okay. I'd like to just add something from my, hold on one second, if I can see if I can figure out how to do this really quickly. I had one slide here that I thought was kind of pertains to what we're talking about. When all this started, I wanted to seek out any knowledge because there was none. I went back to the very last epidemic that this country had and looked at 1918 influenza. And it's funny, I wanted to see if we can learn something from it. And guess what? They're basically doing what we're doing right now. The things that worked, there were no drugs mentioned here. It was the things that worked, all non-pharmacologic. Quarantine the cases. Once you've isolated them, please keep them isolated away from others. Social distance when you're out and about. Cover your face, cover your eyes if you can. School closures, hand washing. This is all from literature in 1918, not 2020. And what I also read and found very interesting is that when the states sustained these non-pharmacologic interventions, they did have the one peak that we're all experiencing, very high peak, many deaths, and then sustained the intervention, and it stayed low until, of course, vaccines came about. However, the states that did not sustain these interventions, as we're seeing in 2020, meaning they never even went down to 0 or even 10, and what they did is reopened before even they were coming on the decline of cases, and what happened is they're now experiencing a very, very second tall peak. And so we're seeing it again, history is repeating itself, and I feel we are reopening too early as a country. And I think New Jersey and New York are doing the best right now is because we are trying to sustain these interventions. So I think our overall goal as a United States should be to slow the transmission of the virus, to not overburden the healthcare system until an effective vaccine is developed and is proven to be effective. Okay, I'll get off my soapbox. All right, Brittany, last question, I think.
Yes, an attendee is wondering, is a sudden nosebleed a symptom?
It's a very, very non-specific symptom. We have not seen it present commonly in COVID, and we see it so commonly at almost every season. We see it in winter because it's too dry. We see it in the spring because of allergies. We see it if you have a sinus infection. But it's rarely due to something like a viral infection or medication related like blood thinners. So we would have to kind of get a history from that person and see if there's another plausible reason for it. But no, I wouldn't say right now, 3 months into it, that that's a common thing that we've seen.
Thank you.
Thank you. Thank you for all the questions.
Thank you.
So Ashkan, if you could allow me to wrap up here.
Sure.
Thank you so much. Thank you, everyone. This was a very productive hour. It was very ambitious, I think, of us to try and tackle such a topic in 1 hour, but thank you all for such a great job and sharing your stories, your expertise on this very important issue that we're sure to circle back to, I'm sure. I do want to thank, again, Gail Foreman for organizing today's event. Couldn't have done it without her. Dr. Andrea Inazelli, Dr. Megan Riley, and Ms. Nora Casper. I'd like to also thank them for their many, many contributions. Thank you, Dr. Ballard, Dr. Ashnawi, Dr. Randall for participating on the panel. The recording will be available on the Rowan SOM alumni page, probably within the week. And then I just want to tell everybody that our next webinar, and we are going to try to do this monthly, will be Wednesday, August 19th, when we explore really fascinating and timely topic. The title of the talk is Every Pixel Tells a Story, Don't It? Staying Human in a Digital World. This is with our SOM alumnus, Dr. Dan Waters. So look out for announcements and web links for that, and many more to come in the fall. So with that, I want to thank everyone and wish everyone a good night.
Thank you.
Thank you, guys.
Thank you.
Thanks, Ashkan.
Thank you, guys.
Take care.
Thank you, everybody. That was wonderful. Thank you.
Thank you, Gail.